Welcome to this PK University Stanford Joint Seminar on Health, Economics, and Policy. I want to thank Dr. Yang Jianan and Dr. Pan Yuhan for putting together this great panel of speakers for our joint seminar between PK University and Stanford. As we can see, we have been fortunate to get a number of great scholars to share their recent research through this seminar series with focus on health economics, health policy in both Asia and around the world. And as we speak, most countries, including United States, are in a relatively free track to enjoy your work and your life, while China is still under some regulated settings because we're still facing Omicron virus challenge. So we have to deal with it at the moment. But thanks to the great technology, we are able to continue our academic work through platforms like Zoom, as we do right now. Hopefully, we will have better settings in the future to conduct both online and offline activities, both in Stanford and in PK University someday, hopefully soon. I really look forward to the great research presentations from our speakers, and it's very interesting to see Dr. Huang as the first speaker with the very sexy title, Too Busy to Be Cured. I think that's a great research topic, even though the topic itself is quite a classical topic. He really has put together some great data and using recent methodologies to address this classical issue. I hope his research will provide us with a great insight for us to better manage our life between something we want to do and other alternatives under time constraint. So I hope we can better provide the solutions to many other questions in our life. Too busy to do something, too busy to learn something, through his seminar, I hope we can make a better choice from his economic insight. Okay, so I look forward to his talk. I'll give the time back to our moderator, Dr. Yang Jianan. Okay, back to you, Jianan.
Thanks, Professor Liu, for the opening remarks. So good afternoon and good morning, everyone. My name is Jianan Yang. I'm a postdoc here at the Asia Health Policy Program at the Shorenstein Asia Pacific Research Center. So it's our first webinar series of this academic year, and as Professor Gordon Liu mentioned, this year we are delighted to have the Peking University Institute of Global Health and Development jointly hosting the webinar series with us. And we will invite researchers around the world to talk to us about a range of issues related to global health and especially Asia health. So I hope you could stay tuned for our events announcement for the rest of the academic year. So now I'm delighted to introduce our speaker today, Professor Huang from the National School of Development, Peking University. Professor Huang was an assistant professor at Emory University and the National University of Singapore, and he received his PhD in economics from Harvard in 2016. And his research fields include public, labor, and health economics. So Dr. Huang will talk to us about the time cost of seeking care in China and the United States. And so for our audience, if you have any questions that you want to ask Dr. Huang during the talk, please enter them in the chat box and I will come to them after Professor Huang finishes his part. So Dr. Huang, without further ado, over to you.
So yeah, it's a great honor to speak here. So the title I would like to present today is "Too Busy to Be Cured." Actually, I started this project a few years ago, and very fortunately, because I once was a visiting scholar at Professor Liu's group. So during that time, I used a part of the data here, and actually I combined the part of data from myself too. So this project actually is collaborated with my friends and also my students. So it's collaborative work with Ding Xiangyuan, Ren Changyu, and Zhou Yi. So today, let's start about too busy to be cured. So first is that this is outline for today's presentation. In the beginning, I will show the motivation and what's the research question. And then I just show a very, very simple framework, how we consider time in the healthcare. And then I will go to the background and data and how we address the endogeneity issue and how we show the impact of time cost on the healthcare usage. And then about the empirical results. Actually, we have two sets of the policies, exhaustion policies. And then I'll come to the conclusions. So first about the motivation. And we see that the health literature usually emphasizes the monetary cost of the healthcare. Just like Pauli, 1968, for very, very early ER paper. In that paper, Pauli says a lower price leads to higher quantity of healthcare usage is somehow a definition of the moral hazard in the beginning. And nowadays, as one recent studies by Amy Finkelstein and Liram, and there are some reviews about current empirical papers reviewing the moral hazard. So they actually, unfortunately, nowadays, the empirical papers in health economics abuse the term of moral hazard. So usually they treat the impact of health insurance on medical spending as the effect of moral hazard, actually, which is not so accurate. In general, actually, people use the price elasticity of demand for medical care as an important measure for the moral hazard. So there are two sets of famous examples. One is RAND health insurance experiment happened in the 1970s, and the Oregon Medicaid lottery in the 2008. Actually, there are in between and afterwards, there are quite a few research papers investigating how health insurance affect the healthcare usage. But most of that focuses on the monetary cost of the healthcare. As that is what we are interested in because that's really positively related. Once we have the price elasticity of demand for medical care, we know we'll predict how the healthcare expenditure change over time as the price changes. Okay, so yeah, but one thing is omitted is that out-of-pocket price is not total cost of medical care for individuals. When people go to a hospital, is that out-of-pocket price is just a thing in their mind, or is there any something else? So my research start here is that no, people do not just consider out-of-pocket price here. So this one photo from one hospital in China. So when people go to a hospital, there actually is a really, really long queue. But I know recently because of digital economy, because of digital technologies applied, this phenomenon has been fewer and fewer. But still, healthcare takes a lot of time, especially inpatient care, right? Inpatient care that you have to stay in hospital rather than ask someone to stay in hospital instead of you, right? So this is one phenomenon. And there's one recent survey in actually this survey happened in Qingdao. Oh, because the words here are in Chinese, so let me just introduce the words here. So it says that are you illness? Then go to hospital. The people on the right says, yeah, but no time. But so this survey says that about 60% of people do not have time to go to hospital to take care of their illness. So they have to work with illness. So this is the current situation in China, I guess maybe in many of countries all over the world. So this is my research question. What's the impact of time cost on healthcare usage? And this actually is talk to the question about moral hazard. Because moral hazard, when we talk to moral hazard, we usually think about the price elasticity. But the price, is that price only monetary price? And how about the opportunity cost? So this paper investigated how healthcare usage is affected by the change in time cost. And we investigated two natural experiments. So the first experiment is a retirement policy in China, both in China and the United States. And we compare those people who are supposed to be retired and so who are supposed to working. Because in China, we have compulsory retirement policy. And for the male workers in the urban regions, the men actually retire at 60. Most of them retire at 60. And for the United States, we have elastic retirement policy and people retire at 62, between 62 and 65. And then we also have another natural experiment, that school starting date for age-eligible children. So actually, I have the administrative data from one city, and we can see that whether the children are still in the hospital once the school starts. So children also be there as well, right? So we can compare the hospitalization performance or hospital admission outcomes, the difference between when there is in summer vacation or when there is a semester period. So today's methodology is regression discontinuity design, RDD. So all my studies are based on the regression discontinuity design here. And I would like to say that because of the time limits, I will not show the regression tables here. So today I just want to show some figures, very interesting figures. And those figures are very illustrative and very, very straightforward. And for the retirement that we used detailed individual panel data in China, there's a 9-city survey data and a CFPS data and repeated cross-sectional data in the United States, which is very famous, and HIS data to investigate this issue. And then we also investigate the school starting date variation and by using the administrative data from CTS in China. And we have a very detailed hospitalization record for everyone in the city. Okay, so here are main findings. So here is that time cost matters significantly for inpatient care usage. And we do not find much evidence for outpatient care usage. So which means that inpatient care is sensitive to the time cost. Because that may be straightforward, right? Inpatient care cost will take a lot of time, but outpatient care maybe not. And we find that using retirement policy, use 62 in the US and 60 for men in China, that we find that first, in the retirement policy after the retirement age, the employment significantly drop, which is very, very significant. And meanwhile, inpatient care increased by 20 to 30%, which is large and very, 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 which means that the time cost actually captures a lot of opportunity cost in the component. And we also find that in the household, they also spend higher household expenditure proportion in the healthcare. But meanwhile, we do not find significant changes in outpatient care. In household total expenditures, health measures, and insurance status in the two ages for the 62 in the United States and the 60 for men in China. And then the second experiment, we use school starting date as experiment, and we find that proportion of being hospital among the age-eligible children declines by 15 to 20%. just before and after the September 1st, and then more discharges before the threshold, which means that the parents just get discharges of their children just before the school open. And we also find the result is only matters or only in place for school age children, which means age 7 to 15. For those children aged below 7, or for those kids, or maybe those kids for the adolescents aged above 15, we do not find any significant results here. So this is the main findings. And then before I come to the conclusion of that, so let me just show what's the framework and what's the data and background and what's the empirical result, then we'll come to our conclusion. So first, there is a simple Bakerian framework from Aguirre and Hurst, which published on JPE 2013. So this framework is from there. And they assume there's time separables with concave utility. And utility equals to a function from the consumption C1 to Cn. For each consumption Cn, they require two inputs, Xn and Hn. Xn is a monetary input and Hn is time inputs. Xn, which means Xn means how much you need to spend. And Hn, you mean how much time you have to involve in that. And let W, the cost of time, and sigma m, the elasticity of substitution between time and market input, which is between Hn and Xn. Then they have such equation, which means that the Xn, the monetary input in that commodity or in the consumption, will change as the time cost changes. The equation is that Shn sub h and up n, which is the time share for consumption n in the life, which is a positive number, and sigma n, which means the substitution between time and market inputs. And then they will subscribe one positive number, which is the risk aversion utility, the inverse of the risk aversion. So then, which means that when sigma m is very large, for example, when the time and the market input can substitute each other, the elasticity is very high, then this equation will be positive. This used to, you may imagine just like have a meal. You may have a meal outside or cook by yourself or ask someone to deliver the meal to you. So which means that if you have time, then you may want to cook by yourself. And then, however, if you do not have time, you may ask someone to deliver for you. But once you ask someone to deliver for you, then give them the same food, then you have to spend more. So this means that when the money and time can be substituted with each other, then sigma n very, very positive, then H is positive, which means that when you have the lower time cost, for example, when you're just retired, then you can just go the supermarket to search food for yourself and to search the vegetables, the meat, and then get them back home and cook by yourself, right? But however, if you're too busy, if the W is very large, when the W increases, then you may ask someone to deliver for you. So which means that as the time cost increase, the Xn will increase, the monetary input will increase. However, when it comes to the healthcare usage, for example, inpatient care that if in most cases, you may not ask someone to stay in hospital instead of you, right? You may spend a lot of money, but you have to stay in the hospital. You have to have a rest by yourself, right? So it actually, for healthcare usage, the time and the time and the monetary cannot be substituted with each other very perfectly. So for the medical care, especially inpatient care, time and market inputs may be complements, which means the sigma n should be very small. In this case, we'll find that the Xn, the monetary input, will decrease when the time cost increase. So which means that once you have time, once you do not have time, become busy, then then the healthcare the healthcare consumption or healthcare usage may decline. So then we'll investigate two natural experiments here. The first experiment is a compulsory retirement age in China, and also the retirement age in the US at 62, and then schooling starting date, as we mentioned. So let me just introduce the background for the two natural experiments. The first experiment is retirement policy. So in China, that there is a mandatory retirement age. So people eligible men, retirement eligible men will retire at 60 years old for most of men who are in urban regions. And we also know that for those people, the health insurance scheme changed little for those eligible people. So that's different with the US. US actually, the people usually, the retirement age in the US is 62 to 65. And the 62 is named early retirement age. So it's eligible for pension, but not for medical care. For Medicare actually is become eligible when people become 65. So 65 is normal retirement age. Medicare is available. So Professor David Card have a couple of few papers on this point. How about the universal health insurance impact on people's healthcare usage? But we know that as a retirement, there are a lot of other things may change. For example, income, health status, consumption, taste, preference. There's a lot of things may change at that point. So here we use the RDD, regression discontinuity, to investigate how the healthcare usage change, and we also examine all the other possible covariance change at 60 for the Chinese data and for 62 in the US data. So the retirement policy, we use different set of data. The first data is from individual panels in 9 cities in China. It actually runs for 4 years so for 5 years maybe, 2007 to 2011. And for that data, we have detailed demographic information, healthcare usage, and most importantly, we have details for inpatient care usage for the last inpatient care visit. And also, we have the information about career information before retirement. So what's your career before retirement, which help us to accurately identify whether people are eligible for the retirement scheme or not. And then for the Chinese data too is for the nationally representative data is CFPS 2010 to 2018, which about 4 waves. And this is also individual panel and not much in healthcare usage, but provide some information about the inpatient usage. So we use this data to double check whether the result holds for the national representative data and whether the magnitude actually match each other. And then for the US data, actually, we use the NHIS data, National Health Interview Survey, from 2003 to 2014, because those data, we have detailed the birth month information there. And this is US representative and repeated cross-sectional data. It's not a panel data. And we have birth months provided. And then what's most important for the US data is that it have very large sample. So when we combine the two data sets together and we do combine them together, when we analyze the data in China and the US, we can find very consistent findings. And for the school starting date in the SCD, we have very close contact with local education bureau. And in 2010 to 2015, we have conducted the survey that all the 4 semesters for the primary school and middle high school actually start on September 1st. And in that city, we also established the relationship with their administrative government, and we have collected data for all the medical care visit records. And then based on the urban and rural resident basic medical insurance scheme, those students can be covered by that. And those students are also collected. The information for the student are collected in the data. And so the data covered the kids in the school and those after age 1. So the school and those before school and those after school, if they're covered by the URRBMI, then all the information should be there. And so for that administrative data, we have detailed information for each inpatient care visit. how much spent, how much are covered expenses, and for the hospital, for the inpatient care, we know the date they are in the hospital, the date they are discharged, and also we have some basic demographics in the data too. So let's start to see the results because of time, the time limits. The first is the empirical result for the retirement policy. In this policy setting, I would like to see the effect of retirement age on employment and hospitalization among the aging people. And we also want to see whether the results are consistent across different data sets. So this is setting the RDD setting for our paper. Actually, it's a very traditional RDD setting because this at 60 RDD is not used by myself. It's not used by this paper only. It's also used by many papers. Actually, they use retirement policy to see the other things as well. So we follow the methodology from David Carr 2009 paper and establish to estimate the following. The YIT is healthcare usage, just like outpatient care or inpatient care. And after is the individual I, whether individual I in the year T is above the retirement age, 60 in China or 62 in the US. And FAT is a polynomial of the age, whether the age is before, what's the age distance between the current age and the calendar age with the 60 or 62. And delta T is a calendar year fixed effect, and XIT, excuse me, XIT is the control variables, including gender, education level, and region. And for US data, we additionally control for the cutoff at age 65, because 65 is another cutoff for the retirement age. And here, scenarios to follow the previous, to follow the literature, we also class as scenarios as aging quarters level, because it's a running variable. But similarly, we can also class as scenarios at the individual level as well. But that provides very consistent results. So let's see the results. So I do not have regression tables to show because I think the tables are boring to see. So I just show the figures because that would look more straightforward. So let's see that for the eligible men in the non-CD data, how that working proportion, the population of working proportion among the eligible men, that change over ages. And then we find that at age 60, people's labor force participation or working proportion significantly dropped by about 15 percentage points. So this is very large and very significant. And because that policy applies for the retirement policy eligible people, but for women, actually whose retirement age is not 60, we do not find any change at 60. And then for those men who are not eligible for the retirement scheme, we do not find any change in the significant change in the labor force participation as well. So we find that yes, for the retirement policy, who are eligible for the retirement policy, there is a significant change there. But for those who are not eligible for the policy, there's no change. And then when we look into the CFPS data, we find similar finding, but the magnitude here is smaller because here we do not tell the difference between who are eligible men, who are ineligible men, because the data do not have such information about that. So this is a ITT effect, which means that those men may be a large proportion of men who is eligible for the retirement scheme, but here we do not find the magnitude is smaller, right? Because the average impact among the urban men, and about rural men who are in the rural but ineligible for the retirement scheme, and then we find that yeah, there's no change. And for urban women, similar with the women in the last slide, yes, there are no change. There's no significant change as well. And then however, when we look into the inpatient care, so for the inpatient care, that for the eligible for the retirement scheme in the non-CD data, we find that well, there's a large increase. You see, the mean values about the inpatient care is around 10 percentage points per year, And the increase, the magnitude of the increase is 4 percentage points, which means that the percent or relative change is about 30 to 40% around the retirement scheme. So once people get retired, they tend to go to hospital and receive the inpatient care immediately. And therefore, the inpatient care, to see the comparison, we do not find any results, any significant result among women or ineligible men, because they are not eligible for the retirement scheme. And this also helps us to rule out the other possible, the other possible confounding factors. For example, once people get 60, they feel uncomfortable, they feel they need to go to hospital. So this just tells us, yes, the effect only can be found among people who are eligible for the retirement. For those who are not eligible for the retirement, we do not find any results. And then this is similar for the CFPS data. For the CFPS data, similarly, because a small sample, but still we find that the inpatient care still increase significantly, although there's at margin, as we mentioned, because men here include eligible men and the ineligible men. But still there, we do not find any significant result for the rural men and urban women either. And then we come to the US data when we use NHIS data, that we do find the employment significant drop at 62, which is about 3 percentage points. Because the elastic retirement scheme, the US change is not as sharp as China, because China have the compulsory retirement age, but US is the elastic retirement age. So we can see a smaller change, but the decline is persistent. And then for the inpatient care, we also find a significant increase as a point. Also note that the scale is also smaller. Note that for the China, the scale is about 4 percentage point or 5 percentage point, but here is just 1 percentage point. Note that because the magnitude for the redeployment actually smaller, is about 1 scale smaller. So which means that inpatient care is also almost 1 scale smaller. But when we compare the result, we may see the magnitude between the US and China can be comparable, because when we divide them by the labor force participation, we can find very consistent result. So in general, using Chinese data and US data, we both find such a consistent phenomenon that after retirement, people's employment decline significantly, and inpatient care increase significantly. So we also look into different healthcare related outcomes using the 9 city data, because it contains detailed information about the healthcare related outcomes. We do not find much increase in physical examination behaviors, and we do not find any significant outcomes in the outpatient care. So which means that maybe not a reason driven by health. If the health driven, then we'll find how outpatient care should increase more, because outpatient care is maybe more sensitive, right? The explanation, as we will show later, is that outpatient care is not so time consuming, but inpatient care is. And then what's interesting here is that we find that for the physical exercises, people tend to have significantly higher physical exercises after retirement. So there's one phenomenon in China especially among the women, is that once they get retired, they usually dance in the on the square, especially in the early morning or in the late evening. So you can see that the physical exercises, they are not, maybe have nothing to do with time. Have nothing to do with money, but they have time, they can do that. So it provides suggestive evidence or supportive evidence that time matters for the health behaviors here. And then one thing I need to test is RDD McGarry test, because to see whether the age is manipulated, because the age are reported. So actually, for our survey, for our data, they do not have any incentive to report different ages, right? So we can see that all the ages are smooth before and after the age 60, and or for Chinese data, and 62 for the US data. We do not find any discontinuity in the age density here. And then we also test whether whether the health insurance change different at different age threshold. In China, because of the policy scheme, we do not find any change in the in the health insurance participation rate, we do not find any significant change there. And you can see that going without any health insurance, the proportion is very small. It's just about 4% before and after, and the change is insignificant either. For the US data, we also find at 62, there are insignificant change at health insurance participation. But at 65, there's a decline in the proportion going without any health insurance because of Medicare became available. So we can see that the discontinuity at age 62 in the United States may not be driven by health insurance participation. And then we examine the health outcomes using the 9-city data. We do not find changes in self-reported health, in self-reported health change, in BMI, in any depression. So for any measure in health, we do not find much significant change using RDD testing. One reason for this is that we measure age by quarters. So when the age by quarters, it's become very high frequency of. I mean, high frequency means compared to the other economic data, not to the financial data or finance data. Because financial high frequency maybe go to daily data. So here means when we measure the age by quarters, we do not find that significant change in health change and the outpatient care and other things. So this provide evidence that the changes in patient care may not be driven by the health. And also we look into the household level outcomes, just like household size may not change much, marital status do not change much, household income may not change much, and household expenditure do not change much as well. Because in China, the retirement replacement rate actually is very high, and people, when they retired and they get pension, some people are still working, at other institutions. So we can see that the household income do not change much, and household expenditure do not change much. Actually, I have another paper to investigate this why we do not have the retirement puzzle, and that paper is still underworking. So this phenomenon is also very interesting in China. I know that. And then we want to push the evidence that it's caused by the time cost rather than by the other things. So we divide the income, especially the income before the retirement, because that will be a proxy for the time cost. We divide the income by the lower income group and higher income group. So this result shows you the lower income group. The working proportion, or the proportion of working, also declined significantly at age 60, but we do not find much change in the inpatient care here. However, when we go to a higher income group, which means that time cost is high for those people who are too busy, and we find also working proportion also decline significantly. However, the inpatient care here now become much more significant and very large. So which suggests that the time cost matters here. But however, is it just time? Is there anything else? There may be, for those two groups, the time cost is different, but the people here are different. Some people, that they may have different taste, they may have different value of health, So we also push this forward by looking into the different time cost. Before that, we look into whether the stay in hospital, the length stay in hospital changes before and after age 60. So we look into whether the last inpatient care visit, whether the visit is more than 7 days, it's more than 2 weeks, or more than 1 month. And we do not see much significant change here. So which means that before retirement and after retirement age, the length of stay do not change much. So which means the total time cost may not change much. But what changed here is that they also ask you that how many days of work affected by the hospitalization. Here we find that, there's a significant jump at age 60 for urban men. So which means that these inpatient care before age 60 actually affect their work. But after age 60, the proportion become much smaller. So which suggests that the time cost before and after the age 60 actually change or declines dramatically. You may ask that because the number of days do not change, so what happens? So another question is that how many days of daily life or life activities are affected by the hospitalization? For the same group of people, we do not find this have significant change, even we find a positive increase. So number of daily life is affected even more, but number of days of working are affected by the hospitalization is declining. So which shows that the time cost going down dramatically. And so people may ask that, okay, how about the monetary cost, right? Because you show that the time cost actually going down at the age 60. And then for the last inpatient care visit, we look into the total hospitalization expenditure and also the medical expenditure. For the most recent hospitalization or inpatient care, they do not see any change, which suggests that the copayment or the other or the reimbursement scheme may not change. If they're changed, then we should see the total hospital expenditure or medical expenditure change here, right? So we do not find any significant change in the total hospitalization expenditure and medical expenditure. So in sum, we find that people's inpatient care visit increase, but for the per visit expenditure, we don't find any significant change. And for the household expenditure, there's no significant change. So consistent with the model, we find that the healthcare expenditure proportion in the household increased by 2 percentage points. In general, it's increasing, right? Because people are aging, but at 60, people's consumption proportion or healthcare consumption proportion increased by 2 percentage points. The pre-mean value is about 11%. So which means that the healthcare expenditure proportion increased significantly. And then this is the first experiment. Then we'll have a shorter time to look into the second experiment, is the school starting date. So we want to see whether school starting on September 1st and whether the children are still in the hospital or not. So this is the result. So we have all the records for all the children in the city. And we find that among the city, the proportion of children in the hospitalization, in the hospital, the proportion is around 2 to 3 percentage points. So, that's normal number. However, the proportion of children in the hospital before and after September 1st, just by day, it's a significant drop. The percentage point is 0.2 percentage point. Compared to the mean, actually it's a 15% compared to the mean value. So this sample is age eligible sample, aged between 7 to 15, and threshold is September 1st. So which is a treated group and the correct month, the date. However, when we look into those aged younger who are not school eligible, they are not need to go to school at 2 to 6, and also use the same threshold, we do not find any significant decline. Even there are a little bit increase. So what's happened there? So which means that it's not driven by the hospital side or health supply side defect or patient or parents' opinion. And some people may ask, is that because of the beginning of the month? In the beginning of the month, maybe some effect like that. So we also look into the age 7 to 15, but still we change the date from the September 1st to August 1st. Also, here we find no significant result here. So which suggests that when the school starts, the probability of the children stay in the hospital decline significantly. And those who are ineligible do not. Those are not the September 1st do not. And then we look into whether it's less admissions or less discharges. We find that for the hospital admissions number, they do not change significantly. But what's interesting is that hospital discharges actually change significantly, which means that the parents, when they take the kids to the hospital, and then they will do the discharge just before the school starts at September 1st, which suggests that the parents actually have preparation for the kids for the for the inpatient care visit, they will do some preparations and calculate the days and whether the days are nearer to the school start. They will, okay, we can discharge now and you can go to school. So why this is true? Because when the school starts, the parents do not want to the kids to to have some effect or have some impact on their schooling, right? So this is another term of the opportunity cost of time, because the time after September 1st become much valuable. The time in the vacation is not so valuable to in the substitute in the opinion of the parents, right? So we also look into the other outcomes. Length of stay do not change much, and total expenses in the hospitalization for the kids do not change much, and out-of-pocket expenses do not change significantly either. So we can see that the illness or disease, the expenses here do not change so much. But what changes is that the parents have some preparations, and then they want to, and the parents want to make discharges before the school starts. Okay, so there are some discussions for the results today. First is about moral hazard. So previous literature discussed the out-of-pocket price in healthcare as the total price. But here, in this paper shows you that time cost matters. And it actually captures a significant part in the total cost. If I base on traditional elasticity, which means that the time cost actually is about 40 to 70% in the total cost based on my estimation, especially in China. And for the policy implication is that cost in the universal health insurance coverage, is that covers the time cost or excuse me, or the monetary cost, right? So time cost is actually overlooked in the previous literature. For the time cost, we know that hospitalization very monetary costly and time consuming, and their time cost literature consider about food expenditure and the other things. So here we add the healthcare expenditure, we add healthcare usage here to in the realm of the time cost discussion. And so it shows that the time cost and the monetary input may be complementary with each other in the inpatient care. And also it answers to the established literature about retirement puzzle. Because retirement puzzle happens or exists in every country, during the retirement, before and afterwards, people consider consumption change, but little literature considers the health care usage change. There are tons of papers there are a strand of literature investigating how retirement have effect on the healthcare usage. However, the results are really mixed. There are some increased, some are decreased, some are unchanged. So this paper also provides a new insight into the puzzle of the retirement. Why sometimes retirement have the positive effect or sometimes will have negative effect. It may depend on the time cost, may depends on health insurance change, may depend on the may depends on the co-payment and the other things. So let's look into the mechanism to that literature area too. So it comes to our conclusions. So this paper investigates retirement policy and also the school starting policy to see whether the time cost matters for the inpatient care or healthcare usage. And we find that labor supply responses and how the healthcare changes as threshold. And we also look into the school starting date policy to see whether the kids the hospitalization behavior change before and afterwards. So first, here are summarized for the results. So employment significant drop has a threshold, the hospitalization increased by 15% to 30%. And we see more physical exercises, higher proportion in healthcare expenditures, and more significant among people with higher time cost. And we also find significantly fewer days of work, not life, interrupted by hospitalization. And for school-age children, a significantly lower likelihood in hospital once school starts. And these results provide a more comprehensive picture of more hazard and healthcare usage, and also adds up to the growing literature about time used and about the time puzzle. And those findings have some important policy implications as well. So that's my presentation. So then it's Q&A time, right?
Yeah, thanks, Professor Huang, for the wonderful talk. Yeah, we do have one question from the chat box. I guess it's more of a clarification question about the institutional details, which is like the retirement age of women seems to be different from men. Then can you explain a bit about why you use age 60 at the cut point of female as well?
Yeah, sure. So first, I use 60 for women is not for women's retire. I use women as a placebo test. Yeah, I'm not going to use 60 for women to see the effect of retirement policy, because I just want to rule out the possibility that for the women, for age 60, when people get over 60, is it because their thoughts or taste change at 60, not just retirement? After age 60, that I feel I'm old and I need to go to hospital. So we do not find such phenomena happens for the women. So that's the reason I use 60 for the women to do a placebo test. The reason I don't use 50 or 55, because for the urban women, they may retire in 50 or 55 or in between. So the magnitude when I run, because the magnitude is much smaller than the men, and the women is not compulsory retirement age policy. So that's the reason I do not use that. And because in our sample, because sample size, we do not find significant change in either 50 or 55 for the urban women in the employment. So that's the reason I do not use women in the data, because the policy actually differs in the women. Okay.
Yeah, thanks. So for our audience, if you wanna like speak, unmute yourself and speak, you can raise your hand. I can like put you in the panel list so that you can unmute yourself and talk. So now I see Professor Gordon Lewis has his hand raised, so you can unmute yourself and talk.
Okay, great. Thanks for this very interesting talk, Huang. I have two observations based on your findings. Number one, the health expenditures. I mean, the probability of admissions or discharges change quite significantly before and after retirement. And in the meantime, you examined health-related indicators do not really change much as a result of increase in hospital care. So that is quite consistent with what being reported in previous literature, such as random experiment, meaning people spend more on healthcare services, but obtained relatively little gain in health status. In the random experiment, they only found some gain in health at eye care settings. Otherwise, I recall the increased health expenditures due to better insurance coverage that does not lead much gain in health status. So in that sense, I think what you'll find is well consistent with what's been reported in the previous literature. That's my first observation. My second observation is you find people are more likely to go to hospital after retirement because of the decrease in time cost. This is significant for inpatient care, but not for outpatient care. That is somewhat different from what's being reported in the literature, or what we heard from previous research, because in previous research, for example, in the random experiment studies, we know price elasticity of demand for healthcare is relatively high in the use of outpatient care, because outpatient care is not that rigid in nature. However, the elasticity is quite low for inpatient care because inpatient care is perceived to be more rigid because it's more serious issue. What you find is the opposite with respect to the time cost. That is something interesting, but I think you may want to elaborate a little bit more why we, the people, are more responsive to changes in the price of outpatient care if we're talking about the price elastic demand from, I mean, a monetary price elastic demand. Well, when we switch to the time cost, time price of demand, of elasticity for demand, and then we're different, or we're in the opposite situations. Why is that?
Okay, so that's two observations, Professor Liu, right?
Yeah.
Okay, for the first observation, yes, actually you agree with all the result, right? So number one is the first observation. Yes, I agree with you too. Yes, the RAND experiment told us that the health insurance coverage may not change the physical health much. So we also find that the retirement policy here do not change the health, because health, is a stock that cannot change at a very short time. So this is consistent with the findings. And for your second observation, actually, I would like to elaborate in the paper, because that's exactly the policy implication for the moral hazard, right? Because in moral hazard, when we compare the moral hazard, when we write down the price elasticity, on the up, we use the healthcare change. On the below, we have that the change in the cost. Note that for the outpatient care, we do not have the time cost, because the time cost for outpatient care is not so much. So we just have the monetary cost. And for the inpatient care, is that up is healthcare usage. Below, we have two. Lower part, we have two. One part is monetary cost. The other part is time cost. For all the previous literature, they use the price change, right? For the price change, that's the only factor in the outpatient care. So outpatient care is more sensitive to the price change. However, for the inpatient care, because we have two components, one is price, the other is time. So even a large change in the price, in the monetary price, in the total cost, they do not change much. Why? Because the time cost have a large proportion there. The total change in the cost do not occupy a large proportion. So that's a reason why, let's provide a reason that why inpatient care is less sensitive to the price change, because there is another large proportion in the cost, which is time. They do not change when the health insurance provided, right? So actually, your findings for the two phenomena actually supports our story. So which means that when we consider, as I note right down here, is that when we talk about the moral hazard, the time cost occupy a large proportion of the total cost, which is especially true for the inpatient care. So that could provide another explanation that why outpatient care is sensitive to the price change, but however, for the inpatient care is insensitive to the price change, because the time cost in the inpatient care have a large proportion. So it's totally consistent with your story, actually. Yeah. So I would, yeah. And thank you for the question. I would like to have the opportunity to explain that more. Yeah. Thank you.
Thanks.
Yeah, thanks, Professor Huang. And I'll have like a related thoughts to this. So it's interesting to think about the opportunity cost as part of the price as well. But like, I feel it would be interesting to see, because I guess you have some details of the inpatient care, right? Can we probably see what type of inpatient care got acquired more right after the retirement? Because you would imagine some inpatient care can be postponed, but some cannot, right? And if we see that people actually postpone some like potentially very valuable inpatient care toward the end after they retire, probably we can think about a story where people might be underestimating the benefit of seeking care more timely relative to their opportunity cost at work, right?
Yeah. So actually, there's question in the 9CD data is that they survey the reason why you go to inpatient care. So I do not show the result here. It seems like that there are some disease they know, but they do not have cured before the retirement. So after retirement, they will ask you why you received inpatient care this time. They said that okay, there are existing situation they do not get well treated. Now they get treated now. So I think that's consistent with your observation here. And for the expectation effect, that usually people look into the trend. So look into the trend. When we look into the trend here, we do find some, a little bit decline just below the 60. About 2 quarters here, right? About 2 quarters here, there a little bit decline there, and then starting going out. So which may suggest that yes, there could be some expectations, but such expectations may be not so large to drive the result. The total result not drive by the expectation. So the expectation, there are some effect here, but maybe not the whole story. So that would be my explanation. Yes, the effect of the expectation, there are some component here, but not the whole thing. So that's that will be short answer to the question. So
right, yeah.
I would say yeah. So that also consistent with the time story, right? Because I do not have time, I can post of that. So I will post of that until I have time. Then I will cure that. Yes. So that also consistent with the title. Too busy to be cured. Yes. Right.
Yeah.
Okay. So I can also see some questions in the chat. So let me, because of time limit, let me just answer them directly, right? Okay. So Richard Liang says that have you looked into ratio between number of discharges, number of total current admissions? I would expect increasing number of discharges relative to the number. I look into that. So yes. So consider with your expectation, very consistent with your expectation. That's totally true. So the figure is very similar to this one. Very similar to the figure here. So this is charges per day, and because the total number is almost stable, so we can see that yes, the discharges actually decline at the September 1st. And Chen Danlei have because I believe the RDD in the cutoff point, which is exogenous. Why feeling change point of females can be used as cutoff? Is there any evidence? But the RDD cutoff point should be exhaustion given, which is policy given. It's not say that the cutoff point is exhaustion. The RDD needs that the age is the policy given or predetermined. It's not total exhaustion. So why the feeling change point of female? So I'm not quite sure I understand the question accurately. So why the point change female can be used as a cutoff point. So age 60 are used for both men and women. Age 60 are used as a placebo test for the women, not for the actual price, just for a placebo test. If I want to do a retirement scheme for female, I need to use 50 or 55. But in our data, to be honest, because female can retire at both age and or in between. So we do not find significant change in proportion at using the aging quarters RD setting here. So yeah, so that's the reason I do not use the female in the Chinese data. Okay, so okay.
Yeah, I think aging is allowed to talk, so you can unmute yourself.
Yeah.
I think that would be easy.
Hi. Yeah.
Sorry.
Thank you. My first question would be related to the previous question that so the dependent variable of the indicator for hospitalization is a little bit hard to interpret for me because not all the people need inpatient treatment, and unlike the host said that the opportunity cost might be underestimated by pulling all the people in the sample. So I would recommend, if data allow, if it is possible to restrict the sample to people who have ever been diagnosed with some disease that needs some standard surgery, and use the dependent variable as days between the diagnosis and the surgery date. I think in that way, the treatment effect here would be more straightforward to understand. And that's just my personal opinion. Yeah, but I know like data might not be available. And my second question is, in the analysis, we observe the discharge differences between like before and after the school day, but I think, if I'm not wrong, we don't observe obvious difference in their total health expenditure and like out of pocket or compensation. So it is a little bit hard to understand, like if people they do not spend more money on hospitalization, like they are discharged earlier, why the health expenditure doesn't change with that discharges. And also, I have a clarification question, and maybe I missed that part. I'm wondering if you have income controlled in the specification, because I think the retirement policy mainly, in addition to time, it also affects the financial stream of the households. These are my questions. Thank you so much.
So actually, Yiqing have 3 questions, right? So the first question has been typed here, and we save your time so that you can speak that directly here. So let me answer your first question. As we just mentioned, that we have some information about whether the hospitalization because of the pre-existing disease or the other disease. So we find the pre-existing disease have the large proportion. So they somehow partly answers this question, but we do not have information about whether they're standard surgery or very accurate, the acute disease information that. So I would say that this question or the questionnaire question may help to provide some insight to answer your question, the first question. For the second question, that total expenses or the hospital admissions. So number one is that note that all these length of stay, total expenses, or out-of-work expenses are conditioned on their inpatient care, conditional on the inpatient care visit. So the conditional they are going to visit and what's the total expenses. So this is first the number first one. And second one is that why the total expenses, the length of stay do not change significantly. So these also depends on the parents' expectation, right? Because we find that you see that for the discharges, for the hospital admissions, we find that there is an increase about 2 weeks ago, or this declining over time, right? Actually, which means that before the school starts, the parents send the children to the hospital before that. They have such expectation. I have some disease. Maybe the disease is minor. I know how many days there would be. Usually in China, it would be usually 7 days or 10 days. That's a normal number. So I will say, oh, okay, during that time, yeah, I will send them earlier. Then they will get discharged just before the school starts. So they have such expectations. So then they send the children to the hospital before that, and then discharge just before the school open. So that leads to the length of stay do not change much. So they will strategically change the date of hospital admission. So make that the just before the school starts, they will have a on time discharges. So this is a story, which means that the parents have a good expectation among the kids. For the third point, thank you to raise it up, because yes, there are some important implications about the income change. So number one, I think I conducted the result using the income. Yeah, here on the household income side, on the household expenditure, among the household, I do not find much significant change in income and expenditure, because income and expenditures are endogenous variables in the regression. So I do not include them. So rather than, I would argue another thing is that, as you know, retirement usually lowers the household income, right? And we know that inpatient care and outpatient care are normal goods, which means that even though the income declines and our increased usage of healthcare, such as inpatient care or outpatient care, could interpret as a lower bound. Even the lower bound, we find the effect is large enough to have some attention, because even lower income, we find inpatient care or outpatient care still the inpatient care still increased by almost 30%, which suggests that the magnitude is so large, and we need to pay attention to that. Yeah, so that's my brief answer to your three questions. And I also see another audience, Huang.
Yeah, right.
Yeah.
Yeah, go
before
ahead,
that,
Huang, I have I wonder whether you could present your results by types of disease or by reasons for hospitalization. Because I think for the kids, maybe something like eye surgery for short-sightedness or dental surgeries, may driven your main findings here.
Yeah, I see your point is that, okay, because of vacation, there may be some injuries, right? They play around, there should be some injuries.
Maybe some eye correction, surgery.
Yeah, eye correction and accurate. Yes, thank you for the suggestion. I can tell, yes, I have done something about that. And I do not find significant change before and afterwards, because I can see the different departments I visit and do not see some department that injury or other things change. So in general, to answer your question in short, which means that it's not driven by the injury, it's not driven just by normal disease, it's driven by the, because the injuries or accident are given, are out of expectation, they cannot expect the hospital discharges dramatic decline there, right? If it's driven by accident, then we'll see the hospital admissions will change, right? Because injury after admission. However, we do not find the change in admission, but changes in discharges, which means that parents get preparations for that, not the accidentally injury or accident. So this somehow, so in the paper I wrote it down, but I forget to mention that when I present the result. And I can show you that I also do the injury. The injury do not change much before and afterwards. Yes. Thank you.
All right. I have another concern is for your regarding the senior, right? The result regarding the senior people. My concern is whether your estimate is sort of like a local treatment effect. So for people are very close to like age 60, they may strategically shift their like a hospital visit. They postpone their visiting, but for other age people, they may not be able to do that. So I feel, I'm not sure. Maybe you overestimate that a little bit because that's a very special, group. So how? Yeah.
I see. So yes. So here I would like to say that for the local treatment effect, yes, but I'm not estimating late. I'm not estimating local average treatment because I'm not using instrument. So here I also include those people who do not change their working proportion and look into how the inpatient care change over time, change at 60. For example, for this one, I just see whether people have over 60 and how the inpatient care change on average. Those definitely include those people who do not stop working and who also maybe after retire they're still working. So this result is ITT, internal to the treatment effect of the treated. So which means that this is average effect of the policy rather than the retirement. When we interpret the result we interpret result as effect of the do not working, then we need to very careful about cautious about that, because those people who may subject to the policy and who they do not work, they still work. I mean, the always takers may also change the inpatient care visits behaviors here. So that's the number one question. This result here is not late, it's not local average treatment effect. However, this question applies to the ages. That is true, because for the retirement RDD, we only identify the result or the effect around 60. And whether the result can be extended to before, after, for example, 70 or 80 or 50. So one observation is that we can see the discontinuities happen here, but we do not see any trend they're going down. It's generally a shift. So you can see that in general is very stable and increase over time, but after 60, these shift upwards, do not going down. And even though afterwards the line is still going up more rapidly, which suggests that this result have implications, although we do not have direct evidence whether 60 can be applied to older ages, but at least we can say that our result may apply to those people aged above 60 and above, and the trend do not going down. Yes, so we have some suggestive evidence here, but no direct evidence. Yes, thank you.
Okay, thanks Professor Huang, and thanks for our audience. Seems like it's a very interesting topic, and people are all having a lot of interesting questions. And like for those questions that we might not have time to address, I hope like we could find some other chances to talk to Dr. Huang more about those. But I would like to thank Professor Huang today for sharing your research with us. And thanks all of your audience for joining us this evening or this morning. And I hope to be in touch with you for future webinars. And thank you all again.
Yeah, thank you. Thank you all for all the audience. Thank you for the questions. Yes.
Right.
Okay. So can I get off now?
Yeah.
Okay. Yeah. Thank you. Bye bye. Have a good night or have a good day. Bye.
Thanks.